My name is Dr. Matthew Coates, and I want to welcome you to our surgical weight loss seminar. We're going to talk a lot today about the surgical treatment of obesity and its medical problems associated with it. And I want to thank all of you for your time. I think for many of you, this is going to be the beginning of a weight loss journey where you're going to get a lot of information and then come and see us and eventually head towards surgery and even follow up and learning more about this after surgery. This is just so that you can all put some names to the faces. These are the three surgeons that work in our practice, Dr. Patrick Coates, Dr. Tony Corrin, and myself. So the goal of today's seminar is to educate you on morbid obesity and what the current medical and surgical treatments are for this disease. So what is obesity? In the medical world, it has a very specific definition. Okay? Obesity is defined as an abnormal or excessive body fat accumulation. We use the BMI, or body mass index, which is a ratio of your height to your weight to determine if you qualify for surgery and if you are not obese. Obesity is considered, or you are considered obese if your BMI is 30 or more. Obesity is a disease. This has been known by us for a long time, but has been identified by the medical community and the insurance companies as something that is to be covered and treated. It is a very common disease. So throughout the slideshow, we're going to show you some examples of some of our patients that have had bariatric surgery.
Hi, my name is David Costelli, and I had a Roux-en-Y gastric bypass 9 years ago. Before my gastric bypass, my BMI was approximately 53, 54. So I had problems walking up my stairs at night. I would have to go up halfway up and then stop and wait because I couldn't catch my breath. Since the surgery, my life has totally done a 180-degree turn. I am able to take karate. Like I said, I can tie my shoe without being out of breath. I'm just a different person. My health is so much better. My blood pressure is down. CentralCASurgery was very beneficial to me pre-op and post-op. They were always there for me to answer my questions. The office staff, excellent staff, bar none. The surgeons, top notch. I had Dr. Patrick Coates do my surgery, and wonderful doctor. All the PAs are great. It's just a wonderful organization. They are there to help people create a better life for them.
This slide is to give you an idea of how common this disease is. They show what percentage of the population is obese. And you can see the color coding on the bottom right of the map there, that as you head towards the reds and deeper reds, this is a higher proportion of the population being obese. You can see in California, where we're located, this is about 20% of the population. Now, where we are in Modesto and Stockton area, it's very different. California is a very diverse state, and the demographics in our area here are much closer to the deep south, where you see those colors there for Alabama, Mississippi, where we have closer to 1 in 3 people being obese. So what causes morbid obesity? There are many factors that influence whether someone's going to become obese or not, and it's really not completely understood. We know there are genetic factors, and these relate to someone's metabolism, how they process energy. Food is energy in a sense, and how much we consume and how much we burn in the form of exercise definitely relates to fat accumulation on the body. But some people's metabolism is different, and they will hold on to that energy different than others. And if you hold on to too much energy, you're more likely to become obese. So your genetics are involved in that, your specific hormones and metabolisms. Research is now looking at the microbiome. Bacteria that live in our intestines actually have a lot of influence and have hormonal effects on our body. and this can influence our energy and fat accumulation as well. There are also factors such as the environment in which you live. Certain cities and areas are built more for people to walk around, and they walk to where they're going to buy food and make your own food in certain cultures, as opposed to the areas where we drive in our cars a lot and go through drive-thrus and obtain very high energy, calorie-rich foods. So the food content is important as well. It is both the amount of food that we eat and the kinds of food that we eat, which leads to obesity. So now we're going to talk about the conditions associated with morbid obesity. The very common ones are diabetes, hypertension, sleep apnea, heart disease, joint problems, infertility, and increased risk of cancer. The disease of obesity affects essentially every organ system of our body, from our brains, and can lead to migraines, depression, our lungs affected by sleep apnea and pulmonary hypertension, and our heart leading to heart disease. Diabetes is an endocrine disorder which affects the kidneys, the heart, the blood vessels going to our brains, to our feet, leading to heart attacks, strokes, and foot problems, and the vessels going to our eyes, which can lead to blindness. And this disease, as you can see, does affect every part of our body. Low-calorie diets, high-protein diets, certain exercise programs, and the issue with these treatments is that they have a very low success rate once someone is already obese. Well, they've done studies in university settings where they can have someone with obesity being treated by a multidisciplinary team, including their primary care doctor, a diabetes expert if needed, a physical therapist, a dietitian, and give them access to exercise equipment and follow these patients very closely to try to get them to lose weight. And they do for about a year. And these patients tend to lose a modest amount of weight, about 10% of what they need to lose at about 1 year. And if they're followed longer, by about 2, 3, or 4 years, the weight tends to come back, and if not more. So the success rate using these non-surgical types of treatments is about 3%. That is a 97% failure rate. There are prescription medications for weight loss. We use them very selectively in our practice. They have a small role in some patients. Sometimes when we're getting someone prepared for surgery to get them down to a safer weight, or sometimes after surgery if someone's struggling with weight regain. But these medicines usually can only be taken for a short amount of time due to side effects. They do achieve some weight loss, but again, the amount of weight loss they achieve is modest, usually only about 10% of what is needed to be lost. So the issues with the medications and diets and non-surgical procedures are, as you know, they have a very low success rate. Only work about 3 to 5% of the time, and they also cost quite a bit of money. They've done studies looking at the amount per pound spent, because when people, they'll pay to enter a program, lose some weight, gain their weight back, they pay more to lose it, and after several years they are at the same weight that they were, but they maybe have spent thousands of dollars to end up at that same weight. So we're looking for a more durable, more long-lasting type of weight loss with the surgical procedures. So what are the effects of morbid obesity? And I think this is one of the most important slides of the seminar. The cumulative effect is that it's not just being big. That's all this disease was, and people were just big, but it didn't cause any health problems. We wouldn't be doing these surgeries. And if people wanted to be smaller, that would just be considered a cosmetic or plastic type surgery. But as someone gets bigger, they start having these comorbidities or medical problems associated with obesity, the ones we've discussed: diabetes, hypertension, sleep apnea, and others. And what that leads to is a 2 to 12 times higher risk of death than a non-obese person. This leads to a life expectancy which is 8 to 19 years shorter than someone without obesity. And the degree to which your life is shortened is based on how young you were when you became big and how big you became. This is why we do these surgeries. We do not do cosmetic surgery. We are here to treat the disease of obesity and improve the quality and quantity of your life. National Institute of Health back in 1991 had a consensus conference, and they are the ones that came up with the criteria of who should have surgery, or their recommendation of who qualifies for surgery. And the recommendations are the same today as in 1991. They, at this consensus conference, after reviewing all of the data available, determined that surgery is the only way to obtain consistent, permanent weight loss for morbidly obese patients. Who is a candidate for surgery? These are based on the National Institute of Health recommendations, and anyone with a BMI of 40 or more is a candidate, as well as patients with a BMI of 35 or more if they have a comorbidity or other medical problem associated with obesity. We do not have a maximum weight limit of who we can operate on. We do have a minimum age, and we cannot operate on anyone less than 18 years of age, as that is considered pediatric surgery and would be referred to a pediatric center. And we don't have any maximum age of a patient who is a candidate for these surgeries. We do consider your medical problems. There are a few medical issues which are limitations to whether or not you can have surgery, but most of the time, the medical issues that you have that you have been told maybe that you shouldn't have surgery because of these medical problems, or previous abdominal surgeries or others that you've had may be stopping you from having surgery. Please come and talk to us about these, because this bariatric surgery may be the one surgery that you need to help those other medical problems get better. So we will do an evaluation in our office based on your specific medical problems. We do require that each patient has an understanding of the disease process and the surgical and medical options available. So what is the solution for morbid obesity? Surgery is one option, and at this time it is the most durable, long-term, and most effective option. But it is a tool, and everyone loses weight with this tool in the first year. The question is how much weight are you going to lose, and how long are you going to keep it off? And it's how you use that tool and how you change your life, eating habits, exercise, etc., is how effective this is going to be long-term. But as with any surgery, there is some risk, there is some discomfort, and there can be side effects.
Hello, this is Dr. Koren. So these are the four main surgeries. There are two types of surgeries. One is malabsorptive. Malabsorptive means that you lose weight because you're not absorbing nutrition. The other side of the surgery is restrictive. That means we make your stomach smaller so you can't eat much. That's why you're restrictive. And of course there's a combination, which is a gastric bypass mainly, is that we use both. So normal anatomy, so all the food from the mouth will go down to stomach. Stomach will break down with the acid, but also it's like a mill, so it breaks down your food. And as soon as it goes into first portion of the intestine, it will mix with the digestive enzymes from the pancreas, liver, gallbladder, and that's why our small intestine can absorb your nutrition. Typically, we have a 20 to 30 feet of small intestines to absorb all the nutritions. Here's the simplest surgery. It's called the laparoscopic adjustable gastric band, or lap band. This is a little bit different from other surgeries because number one, this has foreign bodies. Okay, number one. Number two, we do not cut your intestine, we do not chew your stomach. The beauty is that this is very, very slow weight loss. However, that means that a lot of people don't lose weight enough. Okay. Also, the other three surgery, people will lose weight very quickly. This one is the only one, it may take up to 3 or 4 years. So the slow weight loss means that your skin has a chance to tighten up, but again, the weight loss is much less than the other surgeries. It's very easy to cheat, and also it's very, very follow-up intensive. If you don't follow up with the office, it's not going to be successful. So next one is a sleeve gastrectomy. This is number one surgery right now. About 65% of the all surgeries done in U.S. and also the world is this surgery for the last 5 years. This started as a part of the duodenal switch. We'll talk about it. But now what we're making is a banana shape of the stomach. So we'll be cutting out the outer part of the stomach. And then there's no rerouting of intestines. And we found out that you can lose a good weight. And so it became number one surgery for this. So here's a slide showing how the sleeve gastrectomy works. So these are the incision, and we are passing what's called trocar. That's the tube, inside of which we'll be passing different type of instruments, and a camera, and so we can go inside, and we can actually see much closer view of your anatomy than cut open surgery. So here's the stomach, and then food will go into the stomach and pass into the small intestine. First portion is called duodenum. So what we do with the sleeve gastrectomy is that we'll be taking outer part of the stomach with the staples. And it now looks like a banana shape, and it doesn't look like much differences in the size, but that outer part which we take out is actually about 70–90% of the volume. So that's why you can't eat much. That's why it's restrictive and then still help you. And then we also take the hunger drive hormone with this surgery, so you're not hungry after the surgery. So the advantage and the disadvantage of the sleeve gastrectomy, whenever we cut or stitches intestine or stomach, leak can happen. So we have to worry about that. But most of the surgery does that. Nausea, vomiting, again, we are changing your stomach, whether this is the sleeve or any other surgeries. So people tend to have some are very significant, others don't have much of the nausea at all. One of the weakness or disadvantage of this sleeve is also heartburns. If you already have a bad heartburns, this can make it even worse. So if you have what's called Barrett's esophagus, which is precancerous conditions, sometimes this may not be the best options. But again, we have to look at it in all the different your medical conditions. Okay, and sometimes this may not be enough weight loss, and then we may have to do the secondary surgeries to lose weight. Okay, because weight gain can happen. 30%, 1 in 3 will start gaining weight back eventually. With this surgeries, no dumping, and so that's good. Okay, hunger drive hormone, as we talked about it, is gone, so you're not hungry. You do still need to take vitamins because vitamin deficiencies can happen. The strongest really advantage of this is that it's the strongest stomach. So some people who really have a bad joints and that you need ibuprofens and other type of the NSAIDs, you can take that. You have really bad asthmas and you need a steroid, you can take that. If you need a chemotherapy, this stomach can take that. However, as we saw that in the film, we're taking out a part of the stomach, so this is irreversible. We cannot go back. Well, next one is a gastric bypass. Actually, this is the second oldest surgery. It's been done since 1967. Originally done, again, cut open surgery, but now laparoscopically done since 1993. That's when the weight loss surgery took off. With this surgery, this video will show that not only we're making your stomach very, very small. Now that size of the stomach is your thumb or 1 ounce. Okay, so it's very small. And then we'll be cutting the upper part of the intestine and pulling that intestine and connecting to that small pouch. And as you saw that there's a second connection on the bottom part. So the blue is your food. So food will go through very small stomach, and digestive enzyme is coming from the pancreas. It's a yellow. And as you can see, the bottom connection, that's the where the food and digestive enzymes are mixing together. And you still have a pretty long small intestines to absorb nutritions. Okay, so again, advantage and disadvantage. Vitamin deficiencies, just like any surgery can do that. But this one is a little bit more because we are rerouting your intestines. Again, we are cutting intestines, stitching together, leak can happen. Anemia, the iron absorption is very important, also B12, and those need a bottom stomach. So people tend to be a little bit more anemic compared to sleeve gastrectomy. Okay. Bowel obstruction can happen. Any surgery can do that, but there's a very unique one. It's called the internal hernia. We'll talk about that. Also, dumping is very unique to gastric bypass, and this is your friend, and we'll talk about that. Sometimes with this surgery, you can lose too much weight, and then we may have to revise your surgery. And again, just like sleeve gastrectomy, also people can gain weight back. 20%, 1 in 5 will start gaining weight back. Rapid weight loss can happen, and then again, that's why we sometimes have to do the revision surgeries. The beauty of this surgery is a reversibility. It looks very complex, but everything is inside. So if you have any problems, we can reverse it. Okay. Next one is the duodenal switch. This is the most aggressive surgery, and it is malabsorptive. Okay. Because this is mainly losing weight from the malabsorption, we tend to make that banana-shaped stomach a little bit larger than just a straight sleeve gastrectomy, because we want you to be able to take enough food. It's best way to lose weight and then also maintain weight loss best way. But because of the aggressive nature of the rerouting, vitamin deficiency can happen much more. So here's a video of the duodenal switch. Just like a sleeve gastrectomy, we'll be cutting the stomach, but this stomach is a little bit bigger than a sleeve gastrectomy, as you can see it, because we want you to be able to eat food a little bit more better. We don't want you to be too restrictive. Right after the stomach, we cut the first portion of the intestine called duodenum, and then we cut the bottom part of the intestine called ileum, and then we are pulling up that ileum and connecting to that duodenum. Remember, we talked about our small intestine is about 20 to 30 feet. With this surgery, where the food will go through, now the food is going through the stomach and going into the small intestine. Typically, it is about 6 to 7 feet, whereas digestive enzyme is going through the other part of the intestine. As you can see, most of the times food and then digestive enzyme is not meeting together until now, right here. From here to the end of the intestine, small intestine, is only about 3 feet. So imagine from 20 to 30 feet of intestine, you're now absorbing nutrition in only about 3 to 4 feet. That's why you lose so much weight. So here's the advantage and then disadvantage of the duodenal switch. It's much more aggressive, so even more than gastric bypass, you can lose too much weight. As you saw that, the common channel where the nutrition is being absorbed is only about 3-4 feet. So you can have a diarrhea, and sometimes it's too frequent diarrhea. We may have to change that length so that we can control your diarrhea. Most of the people nowadays with the 3 to 4 feet, not necessarily you will have a diarrhea. Definitely you need to take vitamins, more vitamin than the other surgeries. The benefit is that, or advantage is that, again, dumping is very rare. This one, you can maintain your weight loss much, much longer. Again, hunger hormone is gone, so you're not hungry at all. And then now the expert started doing what's called loop to duodenal switch. With this one, there's only one connection. We still make your stomach a little bit bigger than sleeve gastrectomy, but because of the single connection, you are absorbing nutrition much better. And also it's a safer surgery because it's one less anastomosis or connections, and seems to be able to still lose a lot of weight and maintain the good weight loss for a long time. So with the loop to duodenal switch, again, we're making the banana-shaped stomach, even though a little bit bigger than the sleeve gastrectomy. Here you can see the yellow, that's the pancreatic enzymes, which is very important to help us absorb nutrition. With the loop to duodenal switch, again, we are going to make a tube out of the stomach and take the outer part out. So this is irreversible, just like a duodenal switch and sleeve gastrectomy. And then right after the exit of the stomach, or first portion of the intestine called duodenum, we will be cutting that. And then we'll be pulling up about 10 feet of stomach, or intestine, intestine, and connecting to the duodenum. With the gastric bypass, typically 70 to 80% of extra weight is lost. So let's say you were 300 pounds, 5 feet 6 inches, your BMI is 48. Your ideal weight for your height is at 130 pounds. So that means 300 minus 130, or 170 pounds is your extra weight. So let's say 70% of that extra weight is lost. That means about 120 pounds. So you go down from 300 pounds minus 120, or 180 pounds. So your BMI goes from 48 to 29. So that's very, very successful surgery.
My name is Davida, and I had the duodenal switch. Before surgery, I was about 315 pounds. I was pre-diabetic. My sugar levels were crazy, and honestly, I just remember not being able to move as freely as I wanted to. I had small children, and there was no way that I could enjoy my life the way I wanted to. So it's been 5 years, so I will say that my life has improved tremendously. I can run, I can jump, I can exercise, I can do everything that I was not able to do before. I can ride rides with my kids, and I could take those flights of stairs like nobody's business. I wear high heels every single day now, which I couldn't do before. My clothing is completely different. Central California Surgery and the providers there have been amazing. Both Dr. Patrick Coates and Matthew Coates were fantastic with everything that they did to help me get from 315 pounds to where I am right now. And I don't know that I could have done any of this without their help and without all of the staff there, the PAs, and from the front desk all the way to the very back. They are just awesome.
Again, surgery is a surgery, so there are risks to complications. You need to be aware of it. Okay. Mortality means that the chance of dying from this surgery is 0.1 to 0.5%, and it's about the same risk as having gallbladder removed, which is one of the most common surgeries done. Okay. Leak rate, we talked about it. Anytime we cut the intestines or stomach, that can happen, and that's about 2 to 4%. Stricture is a narrowing where we connect the stomach to intestine, and 5 to 10% of the people can potentially have that. Unlike the other surgeries or complications, if you have strictures, GI doctor can put the balloon and stretch rather than needing to have surgery. So again, the risk of surgery is all depend on who you are, how old you are, how high BMI is, your age, medical condition. Very unique to the gastric bypass is what's called the internal hernia, because we are rerouting of your intestine that can happen. It's very unusual with the duodenal switch. All surgery will change your anatomy or size of your stomach, so people will have certain nausea, some people more than the others. Okay. Certain food you loved before, like a steak or so, you may hate it after the surgery. We can't predict what you're going to have. Okay? Most of the surgery, again, will constipate you, so you need to start taking stool softeners, except standard duodenal switch, then you may have a diarrhea, not necessary. Faster you lose weight, potentially you can lose your hair. It's not like you will be bald, but that you become thin hair. As your nutrition gets better after a year or so, your hair will start growing back, so it's not the permanent changes. Dumping is your friend, and again, this is mainly for the gastric bypass. What happened with the dumping or gastric bypass, you can't cheat. We talked about with the lap band and sleeve gastrectomy, you can cheat because you can have ice cream and you're okay. What happened with the gastric bypass is that simple sugar can be absorbed right after your stomach. Again, so these are the surgical benefit. One of the Biggest thing is what's called type 2 diabetes. When you have a gastric bypass, you go home in a day or 2 or 3 after surgery. 80%, 90% of the people will be type 2 diabetes free. Type 2 means that you're on pills. Okay, this is the best diabetic treatment in the world, period. And initially we didn't know why, but now we identified the very typical change in that anatomy is the best ways to treat type 2 diabetes. However, at the 3 months and after that, duodenal switch is still best way to take care of your diabetes, followed by gastric bypass. And again, with the weight loss, quality of life is much, much better. And typically the people identify that 80–90% or more is very happy with their quality of life. Okay, as you lose your weight, again, remember about 10 to 20 years of the higher risk of dying if you stay as a morbid obese person, so you will be living longer. Type 2 diabetes, we talked about it, gout, heartburns, all other the symptoms and the disease condition can be improved. So we've done over 12,000 weight loss surgeries since 2002. Right now, with the 3 of us, we do anywhere from about 1,400, about 1,300 cases every year. And we have a very good outcomes. We have a dedicated programs, dedicated teams, both at our office and at each hospitals. Not only our number of the surgery we've done, we are COE, Center of Distinction, and Center of Excellence. And that's why if you go through our process in hospitals, it is a good outcomes. Think local. We talked about the complication can happen, and sometimes the complication can happen while you're in the hospital. But also, most of the times, first complication can happen more so within first week. So we want you to think locally. Sometimes, understandably, some people come from the Oregons and Nevadas, and then those people may go back. If you're far away, we really like you to stay first week near our area until at least a 1 week post-op we can check you. After that, it's a little bit safer for you to go back. But again, remember, you need to take vitamin. You need to be checked on the vitamins, whether through us or through your primary doctors. Now, we use PA or physician's assistant and nurse practitioners. They're our right hand. They are very, very good with the medical treatment, and they are part of our teams. We're surgeons. We do best in the operating room. So when you come to our office, you may not see us, and most likely you'll be seeing our providers or PA or nurse practitioner. They know everything. We talk about all the patient's care every day, so you're safe. But of course, you're putting your life on with these surgeries and your journey. So if you want to, and you should, want to meet with us, all you have to do is just ask for, set up the different meeting so that you can meet one of us surgeons so that you can ask any question through us. Also, we have a psychologist and nutritionist. They are very, very important part of your success. And also, it's required by your insurance companies, and we have them at their office also. And one of the really good things is that we have so many before surgery and after surgery educational classes, and that's all free. Sometimes you go to the other programs and they will say, okay, everything is set, you will going to have a surgery soon. Now here is the membership fee, $500, $1,000, $2,000. It's kind of ridiculous, but sometimes that's how they get you. It's all free, before, pre-op education, post-op education support. Please use them. More you're involved with these classes, the more successful you are. Frequently asked questions. How long do you stay? It's really depend on what kind of surgeries. Lap band, you go home same day. Most of other surgeries, most of the people just stay overnight. Sometimes that nausea can be a problem, and you may stay 2 nights or so. How long do you have to be off work? Again, it's depend on what type of tool or what type of surgery you had, and also what kind of work do you do. If you're off job sitting, you may be able to go back to work in 3-4 days. But if your work requires heavy lifting and so on, even with a lap band, you may need to take off, 2-3 weeks or a little bit longer. Okay? Do I gain my weight back? We talked about that. Every single surgery, they are just the tools. If you don't work with the tools, you can gain weight back. Okay? We talked about the hair. Faster the weight loss is, sometimes you lose more, but it's temporary. Okay? Any requirement out of the town, we talked about that, think locally. So if you really drive more than an hour and a half to get here, 55 miles an hour, not 80 miles an hour, you need to stay first week close to us. So we can check post-op 1 week, and if you're doing well, you can go back to where you're from. Do I need to take vitamins? You can die if not taking it. So it's very important. You need to take vitamins. You need to also check the vitamins. Do I take the gallbladder out? It depends. With the cut open surgery, we used to take the gallbladder out, but with the laparoscopy, it's an additional surgery. So it's all depend on what type of surgery, what kind of condition is. If you already have a bad gallbladder, we know about it, you're diabetic, we may take gallbladder out at the same time. Do I go home with a drain? Our programs, typically we don't, although at the time of the surgery something happens, we may do that, but it's very rare. Okay? What happens if I lost so much weight and you have excess skin? Your insurance tends to approve if you had a surgery approved. However, what your insurance pays to plastic surgeon is not what the plastic surgeon will charge you. So you may need to start saving money for that. Okay. It's very important, the pregnancy. One of the problems with the comorbidity is that the infertility, you don't get pregnant when you're morbid obese. Okay? And then so you have a surgery, you start losing weight, you look good, you like it, your partner likes you, something magic happens, boom, you get pregnant. Okay, that's great. You couldn't get babies before. But remember, first year, you're losing so much weight, you really can't support your babies. If you get pregnant within first year, your baby can be born with what's called spina bifida. Your baby's spine is not fused. That's a vitamin folate deficiencies. But after 1 year, you're healthy, your baby will be healthy. But the first year, please try to have multiple contraceptives to not get pregnant. Thank you very much for listening to us. Again, we really appreciate your time and attention and looking forward to serving you through your journey.